Okay. All right. So let's get started. So I will give you a couple of ideas or several ideas about co-occurring disorders, what dual diagnosis is, what it is not, because there are quite a lot of misunderstandings. As a way of getting started, it's important to define what is dual diagnosis. Let me do that for you. If I ask you a kind of strange question, would you consider a patient with schizophrenia and broken leg as dually diagnosed? Well, at first glance, probably yes, because there are two diagnoses. And in a way that would be relatively logical. But this is not what I will be talking about. These are two independent conditions that they could have occurred one way or another without each other, and they don't make much influence on each other. What I will be referring to as a dual diagnosis, this is the operational definition, something that I would suggest you to consider at least for the next hour. The dual diagnosis is a coexistence of interrelated, and this is the key word, interrelated major mental disorder and substance use disorder, meaning they coexist at the same time, either independently or as a cause or result of each other. There are different scenarios, and I will tell you more about it. But the important thing is they influence the course of each other. And again, let me emphasize it. This is the key word, interrelated major mental health and substance use disorder. Why is this important? It's important from multiple reasons. One of the key reasons, at least for me, is we have two systems. We have mental health treatment system, we have addiction treatment system all over the United States and in many other places in the world. But particularly in the US, these two systems don't really talk to each other. They have different funding sources, they belong to different cultures, they have different training and education. Historically, they've been developed in a very different ways. Mental health system has been developed by academically trained people first, and then they build the system. The addiction treatment system is built just another way around. People who did not get any help from anyone in the 50s and the 60s, they started building their own system. So this was more practice-based system building rather than educational-based system building. So they've been developed in a very different way. And because of that, they belong to different cultures and they don't necessarily talk to each other. The problem here is that these two systems keep arguing for years. Is this a primary problem or it's a secondary problem? And very often we spend a huge amount of time, actually we waste huge amount of time arguing whether it's a primary or secondary problem, because it doesn't really matter, folks. We're losing patients because the two systems are trying to provide services, playing football with the patients, referring them one system to another. And as a result, we usually lose patients somewhere in between. This is not a good system of care. Definitely in the United States, this is one of the most prevalent and the least effective ways of doing business. So let's take a look at the science and let's do some thinking together. So why do we need to talk about co-occurrence of two, could be independent, but clearly interrelated conditions? Well, we need to answer a couple of questions. When we see two conditions happening together in one person, we need to decide which one should we treat. Secondly, because the conditions interrelate, so they change the course of each other, we need to decide what is the best therapy. Because the best therapy for bipolar disease could be in some way problematic for opioid use disorder. So if you have a patient who has both problems present, how to approach that? And we need to know how the disorder and the treatment will interact with each other. Example, those of you who are interested in working with trauma, I think, Dania, you said you want to know how to work with trauma in patients, clients with traumatic experiences. Seeing substance use disorders in PTSD patients, we see it every day. It's very, very common. And we also know that the first couple of days in substance use disorder treatment, the PTSD symptoms will get worse. This is a clinical reality, and we need to know it. And we need to be prepared for that. So we need to really decide, if we're about to start treatment, how this treatment will interact with both conditions. And typically, these are more than two conditions. There are lots of other problems as well. So we are talking about dual diagnosis, but in fact, this is not a dual diagnosis. It's a combination of multiple problems. It's only the two major problems is coexistence of mental health and substance use disorder. In terms of the epidemiology, this is the number of people with substance use disorders in the United States. This is the number of people with mental health problems of different severity and different types. And this is the population that we talk about right here, the overlap between substance use disorder and mental health disorder. In terms of the epidemiology, this chart shows, you will have all the slides, you will be able to see yourself and figure it out. It's not that difficult. The substance that is actually very prevalent, the use of the substance that is very prevalent in people with almost every type of psychiatric disorder is alcohol, by far more than any other drug combined, something that we tend to forget because everybody is talking about opioid overdose, amphetamines, and we forget that alcohol is by far more problematic than all other drugs combined. It's just not politically sexy to talk about it. But the fact is, the alcohol, let's pay attention to alcohol. Now, again, you will have all of these slides. You will be able to see the prevalence of different types of substance use in people with different types of psychiatric disorders. We need to answer another question. Why do we see it so commonly? The co-occurrence of mental health symptoms and substance use disorder symptoms. Folks, let me tell you right away, not every situation, not every clinical situation, when you see both types of symptoms present in a patient means a co-occurring disorder. Remember the definition. The definition of co-occurring disorders is two independent yet interrelated conditions, substance use disorders and mental health disorder. In many instances, we observe mental health psychiatric symptoms as a direct result of the exposure to substances. This is not a co-occurring disorder. These are substance-induced mental health symptoms, and I will tell you a little bit more about it in the next 10 minutes. Why substance use and psychiatric symptoms, why do we observe it so often? First, psychoactive substances can mimic psychiatric disorders, almost all of them, with very few exceptions. So the use of substance by itself can create a clinical picture of psychiatric condition. If this is the case, if the mental health symptoms that you observe are actually a direct result of the exposure to substances, there is a good news. Most likely they will go away within hours, sometimes days, rarely weeks. Again, with very few exceptions. There are some symptoms that tend to stay longer, but very few. In other words, psychiatric symptoms that are a direct result of substance use are likely to go away very quickly without any treatment with abstinence as soon as the person stops using. And it happens within a couple of hours to a couple of days, rarely weeks. There is a common idea that in case of real co-occurring disorders, meaning two independent interrelated conditions, patients who have mental health problems, they start using substances to self-medicate themselves. Have you heard that? This is a very stereotypical, very standard idea, very common and prevalent idea, and this is actually possible. However, clinically, this is much less common than people think. The self-medication idea is not as prevalent because of a very simple reason. Psychoactive substances make psychiatric symptoms worse, not better. There are some conditions, mental health conditions, in which in these patients we do see the use of substances clearly as an attempt to self-medicate. Example, PTSD. PTSD is a classical example when people use everything you can think of to self-medicate themselves, to reduce the intensity of flashbacks, intrusive thoughts, and all of these PTSD unpleasant symptoms. This is probably one of the very few clinical situations of real self-medication. In most cases, mentally ill people do not use substances to self-medicate themselves. There are other reasons, and typically the other reasons go back to the genetic vulnerabilities. Okay, I just addressed that. You also know, or I presume you know, that in the DSM-4 and the DSM-5, the chapter on substance use disorders have changed. Now we are not talking about substance use, substance abuse, and substance dependence, as it was in the DSM-4. Now we are talking about substance use disorders in a range of different severities. This is one disorder from less severe to very severe. And this is how we define substance use disorders. There are some pluses and some minuses in this idea, but in any case, it is what it is. We use the DSM-5. I just want you to know the logic behind it. There is a rationale why use, abuse, and dependence have been combined into one umbrella of substance use disorders with a range of severity. At the same time, let's be mindful we define use, abuse, and dependence properly. Substance use is like use of anything, and that is actually mostly influenced by the market. This is the way you use refrigerators, you buy cars, computers. This is the way people use and buy substances that are currently legal: alcohol, tobacco. So the use is a phenomenon that is defined by the market, by the supply and demand. Abuse is the use of substances under the circumstances that could produce some risks. For instance, if you have 2 glasses of wine at a birthday party, this is use. There is nothing problematic here. Most people do that. But if you had 2 glasses of wine and now you're driving, the circumstance have changed, the situation have changed. So in this case, that could be a problematic use of the substance. So in this case, abuse is something that is defined by the circumstances, by the situation. If you had a shot of scotch, for most people it's not a problem, but if you are a commercial airline pilot and you had a shot of scotch, this situation actually will be considered as abuse because the consequences could be quite problematic. Dependence is a phenomenon that is mostly explained by the changes in the brain neurophysiology as a result of the chronic exposure to substances. So these are 3 different phenomena. And this is one of the reasons why the DSM-5 has some deficiencies. And one of them is combining all these 3 things together, although they're defined and influenced by different sets of factors. But again, it is what it is. I just want you to be mindful, because you will be using DSM-5. I want you to be mindful and don't take it blindly. Just use your common sense. Even though you will be using DSM-5, still be critical to that. All right. As I said, almost every psychoactive substance is capable to produce psychiatric symptoms. Some of them are more capable than others. There are 2 classes of psychoactive substances that are commonly making people experience some mental health symptoms. CNN depressants, alcohol, benzodiazepines, and barbiturates, typically alcohol and substances that we call them hypnotics or anti-anxiety substances. These are central nervous system depressants. They commonly make people experience psychiatric symptoms. And CNS stimulants, amphetamine type substances, and coke. This class of drugs very, very commonly will make people experience some psychiatric symptoms. Again, I'm not saying they're duly diagnosed. I'm saying patients, people who are using those substances, commonly experience some mental health problems. What type of symptoms? In general, there are three clusters of symptoms that people are likely to experience as a result of drug exposure. Mood swings, affective symptoms, typically depression, less likely manic-like conditions, most likely depression-like conditions, anxiety, and sometimes psychotic symptoms. So people develop psychosis, and I will tell you the difference in the next couple of minutes. One of the reasons why it happens goes back to the way the substances work on our brain, and it goes back to the way mental health symptoms get developed. This is the central part of the brain, or we call it affective brain. Let me use my fancy pointer right here. This is the emotional brain, or mesolimbic system, or ventral tegmental area. It doesn't really matter. There are many anatomical names, different names for this part of the brain. The important thing is right in the middle of the brain, underneath the cortex. And this part of the brain is responsible for our ability to experience reward, to experience pleasure. It regulates our mood, it regulates our sleep pattern, and many other important functions. But mostly, this is the emotional brain. Why I'm talking about that? All of the psychoactive substances, all of them, affect this part of the brain primarily. At the same time, if you look at the literature, the recent studies on the pathogenesis of major mental health disorders in the brain, they're looking exactly the same area and almost exactly the same neurotransmission pathways. So it seems like there is a common vulnerability in people who do develop real co-occurring disorders. The vulnerability goes back to the same or very similar brain pathways that are involved in the development of both substance use disorders and major mental health conditions, primarily bipolar disease, schizophrenia, schizoaffective, and some types of anxiety disorders. It looks like, based on the most recent science, the same part of the brain and the same neurobiological mechanisms are involved in the development of both sets of conditions. This is one of the reasons. Now my dog will bark. Okay, be quiet, please. Be quiet, I am working, okay? All right. So far he's listening, but we will see. Okay. Now, in the DSM-5, let me just remind you. In the DSM-5, we have Axis 1 conditions. These are clinical conditions of different types. And if you look at this, at the Axis 1, substance-related disorders, schizophrenia, and mood and anxiety disorders, they belong to the same clinical group, and they made it for a reason. These are clinical conditions with very similar course and very similar life trajectory of the development. This is something that I think is important for you to consider. Axis 2 disorders are mostly personality disorders of different types. And there is a reason to talk about the personality disorders. From our perspective, from the perspective of co-occurring disorders, the most important personality disorder to consider is the antisocial personality. Antisocial personality disorder, the reason why it is important, because one of the clinical criteria for diagnostics of ASPD is the use of substances. In other words, if you look epidemiologically or mathematically, in 100% of cases, patients with antisocial personality disorder will be considered as co-occurring disorders because almost for sure they will have some level of substance involvement. For sure they will have some degrees of severity of substance use disorder. So by default, simply because of the criteria, patients with ASPD automatically can be considered as dually diagnosed because they do have these two conditions co-occurring together independently, yes, yet they change the course of each other. Now, let's go back. Let's start with most common situation. And the most common situation is the affective disorders, emotional disorders. Imagine you have a person in front of you in your office, your social workers or psychologists or researchers, doesn't matter. You have a person sitting in front of you. You don't know much about the person, but what you see, but you do know that the person had never had any problems, at least based on the information that you've got so far. But you see that this person is severely clinically depressed. I mean, it's obvious. You don't even need any testing or neurophysiological or neuroscience testing. You see that the person is very depressed. And there is no any evidence of depression in the history. What would be the first question to ask? Or one of the first questions to ask? What I would ask is, have you ever used substances? If you look at the same situation, again, epidemiologically, in people who have never had any history of major depressive or bipolar disease or any kind of affective disorder, and all of a sudden they're severely clinically depressed, in approximately 60 to 65% of cases, the reason for that is the substance use. And in most cases, alcohol. And it looks like if you look at the people, the subset of people who have alcohol use disorders, almost 100% of them, at least at the beginning of treatment, will be clinically depressed. Even if you use the testing, you will find significant evidence for clinical depression. And it looks like that alcohol actually causes major depressive disorder. And I'm sure you have heard that before from other people. And this is important for us to make sure that certainly it looks that way, because almost everybody with alcohol use disorder will be clinically depressed at the beginning of treatment. But the truth is, the fact is, based on the science, based on the research, this is not the case. Why is this important to consider? Now you will understand why. Imagine you have a group of patients who are very early, the first week in their alcohol treatment. By the way, for non-alcohol substance use, psychoactive substances, the picture will be pretty much the same. I'm talking about alcohol simply because most of the studies are made in alcohol treatment. Almost all of these patients will be clinically depressed the first week in treatment. And it looks like they have clinical depression. If you observe them, if you don't rush with medication, you continue working with them. If you do not rush with medication, by the end of the second week, right here, approximately 30% of them are still clinically depressed. If you wait a little bit longer with the medication, again, I'm not saying do nothing. You can do a lot of things. You can do motivational enhancement, cognitive behavioral therapy, physical and vital function maintenance. You can do a lot of good things. I'm saying do not rush with antidepressants. By the end of the week 4, right here, you will see approximately 8 to 10% of them are still clinically depressed. Now, let me ask you, now you're learning mathematics, statistics, and epidemiology. What is the prevalence of major depressive disorder in the general population? Approximately 8 to 10%. So when you see this group of people closer to the end of week 4, and they're still clinically depressed and you use the testing strategies like Hamilton Depression Test or Beck Depression Test. I mean, there are many, it doesn't matter which one. So when you see a subset of patients who are still clinically depressed at the end of the week 4, this might be the group that actually does have coexisting, interrelated mental health condition and alcohol use disorder. This is the time when I would consider a very careful psychiatric evaluation, and it may be necessary to start antidepressant medication. Why it doesn't make much sense to start antidepressant medication here? Let me ask you folks, how long does it take for SSRIs to start working?
Is it at least 2 weeks?
At best, yeah, at least 2 weeks. Typically 3 to 4 weeks. So if we start antidepressant medication here, around the week 1 or week 2, the chances are that this person will be out of depression without any medication by the end of the week 4 anyway. So you're wasting your time, and we are mugging the whole clinical picture just by prescribing the medication. What I'm saying is, in the population of people with alcohol use disorders who are clinically depressed, if you have a luxury of waiting with antidepressant medication for at least 4 weeks and do careful observation, this is the best strategy. Wait, observe, do something non-pharmacological, and do not rush with antidepressants. If you see a patient with anxiety, severe anxiety disorder, with no previous history of anxiety disorders, what would be the first question to ask, or one of the first questions to ask? Have you ever used substances? Because if there is no evidence of independent anxiety disorder, most likely this person is anxious because either stimulant intoxication or depressant withdrawal. Folks, let me share with you a huge secret that you have never heard before. I don't remember all of the psychoactive substances in the world. There are thousands. I cannot remember the clinical pictures of intoxication or withdrawal for all of them because there are many. I'm 60 years old. My cognitive functions are declining. But the good news is I don't have to, because as long as I know which class of substances this particular substance belongs to, I will be able to very accurately predict what the intoxication will look like and what the withdrawal will look like. Because the clinical picture of withdrawal is just the opposite to the clinical picture of intoxication. That's simple, folks. The CNS depressants, what do they do to the brain and to the people? They sedate people. People become first goofy, they're slower, the speech is slugger, and then they fall asleep, and sometimes they develop a coma and they can die. Okay? So what will be the clinical picture of withdrawal? Just the opposite. People are anxious, they cannot sleep, they have all sorts of anxieties, they're very tense. Exactly the same you will find in patients who are using stimulants, amphetamine type substances. So the clinical picture of withdrawal is just the opposite to the clinical picture of intoxication. So when you see a patient with no previous history of anxiety disorder, who is clearly anxious in front of you, one of the first questions to ask, have you ever used substances? Don't forget that some of the medical conditions, physical conditions, can manifest with anxiety disorders. For instance, the myocardial infarction. Much before the chest pain starts, people get very anxious. So even if you don't see any evidence of substance use, you better get some additional help from the medical professionals, making sure that you ruled out the medical conditions. Women with some hormonal problems, they can be for months and sometimes years experience symptoms similar to anxiety disorders, particularly with thyroid condition. Thyroid condition, very often they manifest with anxiety disorders that last very long. And this is not a real anxiety disorder. This is a symptom of another condition. So even if you don't have any evidence of substance use, you still better make sure that there is no any physical reason for this person to experience this type of symptoms. Before you may consider that this may be some independent anxiety disorder, PTSD, or obsessive compulsive, or generalized, whatever anxiety disorder you can think of. Okay, now you have a client who is a patient who is psychotic. What does it mean being psychotic? Being psychotic means that this person is experiencing hallucinations or delusions. The consciousness is clear, meaning the person is oriented. The person will tell you correctly, today is October 5th, I'm in San Diego, California, having this boring class. The orientation will be intact. But at the same time, the person will tell you, you know what, I know what my neighbor is doing. They're digging a tunnel underneath our backyard. They instill the computer inside, and from this computer, they're stealing the thoughts from my brain, sending my thoughts to the FBI, and now the FBI is instilling their thoughts in my brain, and my neighbor does it because he hates me, okay? Kind of bizarre things. The last thing you want to do is to is to try to convince the person that what he or she is saying is bizarre, you'll be wasting time because of that reason. The person doesn't have any insight. Having insight meaning being critical or have critical relationship with the experiences or the thoughts. For instance, you know, people with obsessive compulsive disorders, they're washing their hands 200 times a day. By the way, right now, this may be not a bad idea, but this could be really debilitating and it will reduce the social functioning of the person to minimum. In this case, if you ask the person, do you understand that what you're doing doesn't make any sense? All of them will say, yeah, of course I do. I just cannot control it. They understand that this is something that is very problematic. That's what insight means. People who are psychotic, they do not have any insight. They absolutely convinced that what they said and what they experienced is true. The insight is not there and the consciousness is clear. So when you have a patient like this, with no previous history of schizophrenia or schizophrenia-like condition or schizoaffective psychosis, the first or one of the first questions I would ask is, have you ever used substances? Approximately 55 to 60% of cases, these symptoms are a result of amphetamine intoxication or intoxication with substances from the amphetamine group. We call them ATS, amphetamine type substances. Sometimes people can develop psychotic conditions due to the medical reason, similar to all other conditions. For example, patients with diabetes, when the blood sugar goes very high, they could be psychotic. And if you don't know that the person has diabetes, you don't think about checking the blood sugar level, you can miss it and the patient will die. So this is quite important, similarly to anxiety disorders and affective disorders. So if you ruled out substance-induced, the nature of the symptoms, you better make sure that there's no any medical reason for the person to experience that before considering any DSM-5 psychiatric condition. Okay. When mental health symptoms are a direct result of substance use, it can happen in 3 different time frames. People can develop mental health symptoms during intoxication. Example, amphetamine type substances. People intoxicated with amphetamines commonly become paranoid, they become anxious, they have a lot of mental health symptoms, and the symptoms will go away with abstinence. In this case, you really don't need to do any heroic treatment, except if their behavior is totally disorganized and present some threat for themselves or people around them, which is not a common situation. It may happen. But unless the person, even if the person is very psychotic or very depressed and there is no threat, these symptoms will go away and they will clear out with abstinence. Some of the psychiatric symptoms can develop during the withdrawal. Typically, the typical example of withdrawal psychiatric mental health symptoms is delirium tremens. Delirium tremens in alcohol-dependent individuals never develops when people are drunk. Even 100 years ago, when people already knew what delirium tremens is, one of the treatments was give them alcohol. The symptoms will go away for a while. They will come back and the patient will die. Now we don't do that. So delirium tremens never develops when the person is acutely intoxicated with alcohol. This is a withdrawal symptom. It always, if it happens, if the DT develops, it develops during the withdrawal, meaning the first 48 hours in abstinence. Some of the mental health symptoms can last longer and they can develop during the abstinence. And one of these typical, very common, long-lasting mental health symptoms, these are not co-occurring disorders, these are substance-induced mental health symptoms, is insomnia in patients with the history of amphetamine type substances use. They commonly have they have a hard time falling asleep. And unfortunately, This is one of the few very long-lasting symptoms. It can last for years, even during the time of abstinence. There is absolutely no any reasons to believe that the person is still using. So you are absolutely sure that the person is in remission, and the insomnia will be a very, very, unfortunately, very long-lasting symptom. And not just insomnia, but the sleep inversion. We call it sleep inversion. This is a very typical for amphetamine use disorder. People cannot sleep during the night, and they're very sleepy during the day, particularly the first half of the day. And this happens because of the serotonin neurotransmission pathway damage, which is unfortunately very long-lasting. Serotonin is the neurotransmitter in the brain that is primarily responsible for the sleep pattern. Why is this important to know? Well, if you run a treatment program and among your clients you have a high percentage of people with amphetamine use disorder, don't schedule appointments 9 o'clock in the morning. That doesn't make any sense because they did not sleep during the night. They're very sleepy in the morning hours. You won't be able to get any work done with them, any meaningful work. Just change your business hours, open your center at 2 p.m. and keep it open until 10 p.m. This is exactly the time when these people, because of the serotonin brain damages, this is the time when these people are the most active. And this is the time when you will be able to get something done. That's why, from the very pragmatic standpoint, it's very important to know the brain physiology. And the reason why you're learning pharmacology and you're learning brain physiology is not just because to get you busy with something. You're busy anyway. It has some practical application to the work that you will be doing. The knowledge and understanding, at least fundamental understanding of brain physiology and the neuropathology of substance use disorder is critical for you. Not just because you will know what to do, but you will know why. This is what's so important for PhD level people, not just knowing what to do. There are many people who know what to do. There are few people who know why we need to do that. And you're one of those because you will be doctors. This is why it's so important for you to have a clear understanding why you do what you do. Okay. All right. Now, a couple of more things. Let me just first summarize what I said so far. When we see people who present with two sets of symptoms, almost always more than two, but two major sets of symptoms, substance use disorder and symptoms related to substance use disorders, and mental health symptoms and everything related to mental health. In this case, we are working under two assumptions. The assumption one, these are people who experience mental health symptoms because they've been using substances. So these are substance-induced mental health symptoms. The assumption number two, these are people who have two independent conditions. They interrelate with each other. And then we're dealing with real co-occurring situation. Answering this, finding out which one of these two options is actually true is critically important because your course of action will be completely different. Treatment will be completely different. And clinically, if you look at these two people at the same time, one is with substance-induced mental health symptoms and another one with independent interrelated two conditions, they will look exactly alike. You won't be able to distinguish it just looking at the symptoms. They almost always look exactly the same way. But your course of action will be completely different, diametrically different. So what might help you? What might help you in finding out what is more likely, what is less likely? In order to do that, you need to answer yourself a couple of questions. So you don't need to. I would suggest it because that may make your life easier. Ask yourself a couple of questions. The question one, is the class of drugs that the person is using capable to produce this particular psychiatric symptom? Example, you have a patient who is using heroin intravenously very intensely for the last 5 years. And now this person is sitting in front of you hearing voices. What would be your answer to this question? Does the class of drugs that the person is using produce this particular mental health symptom? And the answer is a no. Because opioids never make people hear voices. Opioids can produce some other things, but heroin, it belongs to the class of opioids. Opioids do not make people psychotic. In this case, you will certainly, since your answer is a no, you will certainly start looking for some other reasons why this person could hear voices. You cannot explain hearing voices by the use of heroin, even very intense use of heroin. In a different situation, you have a patient, a client with clear history of amphetamine use. And now the person is very paranoid, meaning delusional and very tense and aggressive. What would be your answer to this question? Yes, because amphetamines typically commonly make people paranoid, aggressive, and most likely the symptoms will go away. You will tell me, okay, smart guy, fine. But most of our clients do not use just one thing. They use many different substances. So in that case, how do we answer this question? Well, something that might help you is take a piece of paper, write down, make a list of all the substances that this person had been using for the last 30, 35 days. Go online and find out which of these chemicals has the longest half elimination time. And if this is a substance-induced mental health symptom, this is the substance that most likely caused that. Make sense? Okay. The next question that you really want to ask yourself is, do you have any evidence of fully developed syndrome? Syndrome is a combination of symptoms, a stable combination of symptoms. So the question is, do you see the full-blown syndrome or just here and there some symptoms? For example, in major depressive disorder, the syndrome of depression is low mood, low energy, insomnia, bad thoughts about the person, about the world, lack of appetite, weight loss, suicidal thoughts, and these things go for weeks, days in a row, weeks in a row, sometimes months in a row. This is the fully blown major depressive disorder syndrome. If you see this person being sad periodically or having low mood periodically with no other evidence of really fully developed syndrome, that's an important indication. If there is the fully blown syndrome, most likely you're dealing with substance-induced condition. You also would want to know, is there any evidence of residual psychiatric symptoms during the time of abstinence? Even people with severe substance use disorders, sometimes or very often, they have periods of abstinence. They got arrested, or they got in the hospital, or they decided to get married and they tried to stop, or something happened. It is very important to find out during the time when they were not using, is there any evidence of residual mental health symptoms during that time? And you also want to know what is the sequence of events. What came first, substance use or mental health symptoms? Let me demonstrate it with a clinical case. This is a real patient, a woman, young woman, 28 years old woman, who was admitted to acute psychiatric, UCSD psychiatric care hospital after a very serious suicidal attempt. This was not just a cry for help. She was serious about it. She just was lucky to be alive. So when we had the first time we had the conversation 48 hours later, I got a piece of paper, I draw a line like this, just simple line. And we started the conversation and I asked her a couple of questions. When was the first time you remember you started using psychoactive substances? And she said around the age of 16, she started smoking tobacco, cigarettes, and periodically marijuana. Okay, and I asked her, okay, do you remember anything at that time in terms of your psychological condition? Anything weird, anything strange, anything unusual? She said, no, I was perfectly fine. Okay, and then what happened? What she said, around the age of 18, she started using amphetamines, not regularly, periodically, usually over the weekends with a couple of other friends. She kept smoking marijuana, but now she used some amphetamines. I asked her exactly the same question. Do you remember that time something that is strange or something that you can recall in terms of your psychological well-being? She said, no, I was perfectly okay. All right. What happened next? Well, around the age of 24, she found a boyfriend. They moved in together, and the boyfriend drank a lot. So she started drinking with him. She kept using marijuana. She kept periodically using amphetamines, but now she started drinking with her boyfriend. When I asked her exactly the same question, so what do you remember any strange experience at that time or anything strange? She said, yeah, I do remember. I felt weird. It was kind of, every morning I felt some anxiety, some tension. I didn't feel good. And my mood was kind of low. I was still functioning, but the mood was not good. Okay. So what happened next? What happened next, she got rid of this lunatic and she found a good job in a bank, well-paid job, and she stopped using everything because she didn't want to risk her job. So she got into substance use remission for a relatively long time. And I asked her, okay, what happened with you, this strange depression, anxiety, tension? She said, oh, it went away. I was perfectly fine. Okay, that's an important indicator. And then what happened? And then what happened with the COVID thing, she lost her job. She got panicked. She did not have any support, so she started drinking again. And she started using marijuana again and sporadically amphetamines. And all of the symptoms that she experienced here at the age of 24, all of them came back, but much more intense, much more intense. And she became suicidal and she decided this life is not worth it. Okay. Based on this presentation, what do you think is more likely? Are these co-occurring, independent, interrelated substance use disorder and mental health disorder? Or this could be substance-induced mental health problem? I'm not talking about the full-blown diagnosis. I'm talking about your thinking. What is more likely based on this presentation? In my mind, when we had this interview, most likely we are dealing with substance-induced depressive disorder. It doesn't make it any easier for the patient. It makes it easier for me because now I have more information to deal with and I have something that will inform my decisions. What will be my next step? So my next step will be a couple of quite important things. First, I want to make sure that the patient is safe. Since the patient was very suicidal, in this case, I really don't care whether it's primary or secondary. I really want to make sure that the patient is alive. So we'll take care of that. We'll observe the patient, we'll do the suicidal contract, we'll do everything that we do when we work with a suicidal patient. But then I will educate the patient. And the way I did that with her, I said, listen, based on our studies and based on your history, I have good news for you and I have a bad news for you. Would you like to know? She said, yes. Okay. The good news for you is you are not crazy. Okay? To put it simple. You don't have, it looks like you do not have a psychiatric condition. You don't have a psychiatric disorder. Everything you experience is a result of your drug use. Because the drugs and your brain, they don't get along well. And you experience these things in a way that is a little bit more intense than other people, maybe because of the genetic vulnerability, maybe because of some other reasons, I don't know. But it's irrelevant. Everything you experience psychiatrically is a result of your drug use. which is a good news. You don't have mental health disorder. Here is a not that good news for you. Should you decide to continue using, I can almost guarantee you that all of the symptoms will come back. And every next time will be worse than now. And now it was bad enough anyway. But I have a good news for you. Should you decide to get in treatment for your substance use disorder, stay in treatment and work the program, I can almost guarantee you that these symptoms will never happen again. I know you're very depressed now. I'm sure that for the next week or maybe 10 days, you will still be depressed, although it will get easier. I can almost reassure you and guarantee you that within the next 3 weeks, you will be out of depression, you will be normal you, and all of these things will disappear, which is wonderful. And if you decide not to use drugs and alcohol anymore, most likely you will never experience anything like that. Okay. What I did, I just reassured the patient and I educated the patient. That's all it takes. Relatively simple, but we often forget it because we rely on medications and magnetic machines rather than just simple talking to the person. That's unfortunate. I see my students, medical students, they're very good with all these machineries and computers. They're much better than I am. And these kids, they don't know how to take girl for dinner. They don't have the social skill of talking to people. They lost it because of the technicality of the world. So let's make sure we understand that the best way to work with a patient is just talk to the person in a very reasonable, rational way and present the person some thinking. Don't tell the person what to do. Share with the person, here's what might be useful to you. This is the part of knowledge that could be helpful. Most of my patients in the past, they found this information helpful. See how you can use it yourself. At the end of the day, this is your life. It's not my life. You will make a decision based on the information, but since you're deciding for your life, it makes sense to me, at least to get a little bit information and knowledge, what is it that you are experiencing. Does that make sense for you folks? Okay.
Indeed.
The last thing I want to tell you, in terms of the treatment of really co-occurring disorders, patients with co-occurring disorders, there are different systems. The independent and disconnected models, we are treating people in 2 different systems by different teams at different times. Not terribly effective, actually very ineffective approach. Sometimes in other places, they use so-called sequential model. They have to decide which of the conditions is more prominent and needs attention first. They start with that. And then as soon as the acuity went down, they start treating the second condition. Not a terribly effective approach either. The parallel model are the 2 conditions are treated at the same time, but in 2 different places by 2 different teams. Folks, not a very effective model. The studies are very consistent. The only treatment model that has significant scientific support of effectiveness is so-called integrated approach, meaning treatment is happening at the same time, the same place, by the same well-trained team of people, interdisciplinary team of people. If you look at the research, this approach, integrated, is by far more effective than all other approaches combined. Unfortunately, there are only few examples of integrated treatment model. One of them here is, by the way, in San Diego. In most cases, we continue doing things that have no scientific support at all. All right. There's some slides talking about the planning, treatment planning, and you will see those slides because you will have them available. I don't want to spend time on that because we don't have any more time, and I want you to give you some time for questions. The key thing in developing integrated model is good training. You need to train people well. And this is the reason why Marie actually every year keep doing this training for you guys even though you're not, is exactly to train people in perfect sense. So what I'm saying is not relevant to psychiatrists or people with clinical experience. It's very relevant for researchers, policymakers, and many other practitioners and professionals. Here is a good resource for you if you want to learn more. This is a SAMHSA Integrated Treatment for Co-occurring Disorders manual. You can go online and download it, or you can order it from SAMHSA. And this is my email and my phone number if you need more information or you have questions. Okay. So we have a couple of minutes to, I will answer your question if you have questions, if you have.
I want to say thank you. That was beautiful. It's not the same effect to not be in person, but I am so grateful for your time. And I will let the students ask questions, and then I'd like to close with an appreciation.
Okay, guys, and ladies, any questions, any comments?
I have a question that relates more to the clinical setting of treating individuals. How willing would they be to engage in such treatment where you tell them that actually a big factor of your mental health symptoms is related to substance use, so you have to abstain or reduce? That's another question that I have. Like, do you recommend full abstinence or do you recommend reduction?
I don't recommend anything.
Okay.
And here is why. There are two reasons for that. First, I just present the information. People need to decide for themselves. So I leave them, these are the facts. Here's most likely will happen if you do this. Here's what most likely will happen if you do that. At the end of the day, this is your life. So you need to decide yourself. I cannot do it for you. I can do it with you. It's number one. The second reason is, if we ask ourselves a general question, what any treatment should do, regardless how you call this treatment, Gestalt therapy, pharmacological therapy, dialectical behavioral, it doesn't matter. Any treatment should do four things. Reduce the symptom, in our case is compulsive drug use. Please pay attention, not eliminate the symptom, reduce the symptom. Improve functioning, prevent complications, meaning HIV, hepatitis C, criminality, TB, homelessness, and respect human rights. These are the four things that any activity should do in order to be considered treatment. And it doesn't make any difference for me, how do you call it? These are all semantics. If you call it a exotic Chinese herb psychotherapy, fine. Just show me the evidence that you can do these four things. Reduce the symptom, improve functioning, prevent complications, and respect human rights. If all of this evidence are present, all four of them are present, it means that you're doing something well. So full abstinence or not full abstinence, whatever works for the patient.
Okay, thank you.
Welcome.
Raul or Wayne, do you have a question or comment?
Well, they have my email and phone if you.
Yes, I actually wanted to ask, if I may, with the profile that you gave of this individual that was suicidal,
Mm-hmm.
They had three things that were three substances that were part of this overall. Do we have any understanding of which of those three perhaps may be causing the most harm for the individual?
Right, alcohol.
Okay.
Alcohol. Amphetamines are less likely to produce that because amphetamines can make people paranoid, psychotic, and anxious. She was severely depressed. Amphetamines may develop, and they typically develop, a condition that resembles a depression, but it's not a depression. It's anhedonia, meaning inability to experience pleasure.
Mhm.
And this is, it seems like a depression, but this is not a depression. That's why antidepressants don't work in these patients. In this case, in this woman, the most important substance that actually led to this result, to the outcome, was alcohol.
Thank you. That's something that is important for us to consider in the complexity when multiple substances or more than one.
Right, right,
Thank you.
right.
Thank you very much. Any other? This is the most, I would say this is the most intimate opportunity to ask questions of an expert that you may have.
That's fine. We'll have more opportunities too. I think the virus thing will, like any crisis, folks, every crisis is temporary. There is no permanent crisis in the world.
Right.
This crisis is temporary too. It will go away, it will get better, and we will get back to normal. We just don't know when, but it will happen.
Absolutely, absolutely. I would like to, I want to respect your time, and thank you for your time taking from your family's time. I wanted to express our appreciation for something that you innately do, Dr. Koutsenok, and that is to bring the humanity into a picture of clinical understanding. And that is a gift that you alone bring, the humanity into our understanding and helping us be more effective as we learn. Thank you.
Well, thank you. What I'm trying to do actually is, I mean, definitely bringing evidence-based practices and bringing science and reasons, scientific reasons for everything we do is an important part of my work. There is equally important part of my work bringing common sense. Sometimes it's not less important than bringing science. Just use common sense. And that will help you a lot and help all of us a lot, even if we are not that familiar with the science. But the combination between good quality science and common sense is probably the best.
Fantastic. I will take that message this whole week. Thank you. Thank you very much.
Thank you all. Good luck. I'm going to do math with my son.
Okay. Thank you.
Thank you.
Bye-bye.
Take care. And so perhaps we can just talk a little bit amongst ourselves. And I'm really excited that we were able to record the session, so I can actually make that available for your reference. And I know Dr. Koutsenok will he can share the slides, but you actually have them in the recording. So what I'm going to do is stop the recording,